I'm Helen. I work at Raigmore Hospital in Inverness, and we're a member of the SGRT Community Clearance Mapping Consortium, and we got MapRT back in June, July last year, and have been using it pretty much since in both test cases and clinical. So I'm going to do a very quick overview of MapRT, but because David's gone through it, I'm not going to touch on that too much. And then I'm going to go on to the rationale for the study, for why did we want to treat head and neck patients with non-coplanar fields, and then some results and conclusion. So, yeah, this background you will know, it uses a camera to capture the entire patient's surface, and basically we can use it to improve plan optimization while avoiding collisions. So we've got several workflows that we can do. You can check for collision in the CT if you wanted to drop an isocenter in CT. You can optimize the patient position. Where we really use it is during planning. So we've got a plan on the system. We want to check, can we treat it? And we export it into MapRT and double check. So it eliminates the need for dry runs and read plans. And there's the clearance map. As you've seen before, the areas in red are areas that are going to collide, and anywhere in the dark blue background is where you can actually physically bring a field in through. So will this one play? Yeah, so software in action. So you've got all the parameters you can change. You can look at your gantry angles, you can look at your fields, you can check that it's not going to collide. But what you can also find out, this yellow cross here shows you that even though the fields aren't going to collide, you have a problem moving between fields depending on whether you move the gantry angle first or the couch. And this is something that's really useful to be able to feed back to the radiographers on the treatment machine that, you know, they're bloody good at setting up patients, but if you can say to them on a busy clinic, move the couch first or vice versa, then it's just information that you can give to them and help speed up the workflow through the clinic. So optimizing non-coplanar head and neck, why did we want to do it? Well, we wanted to eliminate the problems we were having with shoulder positioning. Several reasons why that was possible. Was it because of the shells not being good enough? Was it patient compliance between CT and treatment changing? And also, with a full 5-point shell, we were unable to visualize the shoulder position. So we were going to try and coordinate this using shoulderless masks and postural video. And the main reason that we could see that shoulders were a problem was because of all the in vivo dosimetry we do. We use rad-calc EPID, or previously we used dosimetry check, and we were having huge problems with both dose to the shoulders, but also it affecting the PTV down in the neck area. So, did we want to immobilise your shoulders better, or did we want to move them from the equation with partial arcs or couch kicks? I don't mean chopping them off. We might be in the Highlands of Scotland, but we're really not that barbaric. So, you know, leave the patients intact, please. And also, by removing them from the equation, then are we going to improve the dosimetry? Will our current class solution work? Can we obtain a good class solution of machine parameters? It's important to state that with this study, not aiming to get the best possible plan, aiming to get the best possible plan in the time constraints that we have, but that is clinically better when it is delivered. So even if the plan is suboptimal to a coplanar plan, if it's more accurate on delivery so the patient receives the treatment that the doctor is seeing on screen, then that is better moving forward. And also, we need to still be able to do in vivo dosimetry. So there's no point having a field that will come in quite, you know, using MapRT, you could get a field coming in from this area. What we couldn't do on the machine is actually check that it is delivering correctly because we use the imager panel to do the in vivo dosimetry, and that would hit the couch. And this is one thing the clinicians did not want to lose. They didn't want the best possible plan delivered, but no way of checking that it was actually the best possible plan. So this was the plan, it was going to be a retrospective study. We were going to replan with couch kicks, as I found this was going to be an easier to get a class solution than trying to avoid the shoulders with partial arcs. And then we were going to calculate each one, the coplanar and the non-coplanar, on the cone beam CT to compare what the actual treatment would have been in each case. I say this was the plan. Convery kicked into action and we went down the usual Raigmore route of, well, let's face it, I identify with heart. So the very next patient we got after we decided to do this retrospective study looked like this. He was hugely propped up, had a lot of cushions underneath him. His shoulders were not reproducible in the shell. So I thought, you know what? Let's just try and see if this works on this patient. The consultants were for it, the radiographers were for it, with going for the couch kicks. So, yeah, we just decided to go for it. And this was the surface captured on him. So you can see how much he is propped up. He couldn't get his elbows and his arms in any other position. So we had problems getting an isocenter that would work for full arcs anyway. We were either going to hit his chin, his head, or we were going to collide with the bed. So moving to couch kicks actually helped us optimize the isocenter as well. And if we have a quick look at the results on him, we've got the coplanar plan at the top and the couch kicks that was treated at the bottom. And you can see, yes, there's dose differences over on the right-hand side there. So the coplanar plan gave less dose to the midline here, but the couch kicks gave less dose to the shoulders, as you'd expect, because we're not treading through them. And when you look at the PTV coverage, both for the primary in the blue and the nodes in the brown, the plans are comparable, so we were happy to proceed to treatment on this. And I'll come back to a bit more of that in the results. Oh, no, there they are, in the results later. So here we have the coplanar plan calculated on the cone beam CT, and you can see that there's slight differences in DVH curve and the slight difference in organized risk. Now, with the parotids, that's probably because of the volumes just being copied over rather than actually re-outlined on the cone beam CT. The cord and the brainstem, though, there's hardly any difference between the planned and the treated. And we also found that on the couch kicks, in the way the patient was actually treated, again, there was hardly any difference in the cone beam and the actual planned treatment. This was sort of a bit of disappointment because I was, hoping that avoiding the shoulders would make a huge difference, but we rationalised it that we hadn't made it worse. We'd delivered good treatment. The patient actually had reliable treatment on set. It didn't take any longer to plan, and we were now going to go ahead with the retrospective study to see whether this class solution that I'd come up for this patient would actually work. So this is when it's a qualitative analysis. We're still crunching the numbers to see if we can get anything quantitative out of it. We're looking at DVH, dose stats, and the analysis, and any problems for those that were planned prospectively, because, of course, now we'd done the one prospectively, it was like, well, that was, red rag to a bull to me. Just anyone that came through after that got planned with couch kicks. But the two patients I'm going to show you next was part of the retrospective study. So this is the class solution we found for the machine parameters, and I also found that our current dosimetric solution worked. So all the objective constraints that we got in race station needed minor tweaks to optimise the plan to the best possible, but basically what we'd already got still worked using the couch kicks. So this is the biggest take-home point. I'm not saying that the plans with couch kicks were dosimetrically better compared to coplanar plans. What I am saying is when they were calculated on the cone beam CT, they were more reliable, so they reproduced much better. What the doctor saw on screen, if they were planned with the couch kicks, would have been much more accurate delivery. And most importantly, there were also no problems with the plans for those treated. We had the usual, patients lose weight, few other problems with imaging, but nothing to do with the actual couch kick. And we had one patient that had to be reshelled with a full shell because he had significant stridor and couldn't keep his shoulders still. But again, that was nothing to do with the couch kicks. That was just that individual patient. So a few more results. What we've got here is patient A, who on the top we've got the coplanar plan, and here we've got the couch kicks. Retrospectively planned, and as you could expect, the coplanar plan delivers much more dose to the shoulders. And when you look at the DVHs, there's hardly any difference between the two, especially for the PTV coverage. Organ at risk dose We are finding the parotid dose is higher on these, which as you'd expect, because the fields are coming in slightly superior, but they're still well within the clinical tolerances. And I think with a bit of further work on the optimisation goals, we'd be able to reduce those parotid doses. What's most interesting is when you get to see them, so we've got the coplanar on the left and the couch kicks on the right, and the 2D lines on the DVH are the CT and the cone beam CT. So again, for the coplanar for this patient, it's not that much difference, but for the couch kicks, it's much more better looking at the high dose. The DVHs almost overlap, so the treated delivery, if he had been treated with couch kicks, would have been more accurate and more comparative to the planned treatment than the coplanar. This one is even more dramatic. So very chunky guy, very significant shoulders in the way of the field. Again, a lot more dose through the shoulders from the coplanar plan. In this case, the couch kick plan was quite worse for PTV coverage. It was hotter, still within tolerance. The doctor looked at it and went, if you can convince me it's worth delivering with couch kicks, then yes, I would have gone with it. So, like I say, this is the retrospective bit, but if it had been clinical, the doctor would have been happy to go with it. When we get to reconstructing it on the cone beam CT, this is actually what the patient received with that huge hotspot down there. We didn't know about it till it had happened. It was only when we were calculating them retrospectively that we saw this. If the patient had been treated with couch kicks, still a bit of a hotspot, but significantly less. And this is what we're finding is that patients are CT'd and in the mould room and they're tense, they're nervous, their shoulders are up here, they get to treatment and they relax. And this is why all the patients that I've done in this study, they have all ended up slightly hotter down in the nodes. None as significant of this, I've just put it in as this could be what is happening for your patients if you're not doing in vivo, if you're not seeing it. And again, this is a DVH comparison of the two, and you can see the significant tail on the PTV coverage for the coplanar. It's not there on the couch kicks. So, conclusion. Planning with couch kicks, the most important thing, it gives improved reliability of treatment. Might not be the best plan, but the treatment is more reliable. And also, hope there's no one going to quote me on this, otherwise I'll be shot. It might give us confidence to start to be able to move the couch from outside the room, because this is where MapRT has come in. It was instrumental in developing the class solution. Yes, I could have gone into the department. I could have found time on a Linac to actually check this, but that would have only showed me the couch. It wouldn't have shown me any problems with the patient. And also, let's face it, I'd much rather work from home with a cat on my knee in my pyjamas than have to trot into work and, get on a Linac. So it does help you in your clinic workflow if you are able to work remotely. You don't have to find the time on the Linac. You can have a brainstorm at midnight and think, oh, I wonder if that would work. It's so useful for that. It's quick. And like I say, if it gives us the confidence to move the couch from outside the room because MapRT gives you information about collision when moving between fields, then that is something that is going to benefit the radiographers. Because they don't mind going in the room to move the couch, but they'd love to be able to do it from outside the room. So future work, staff training. Kid you not, it's happening right as I'm stood here, because I got a message from one of my colleagues this morning saying, good luck with your talk, I'm planning a head and neck with couch kicks as we speak. So she's actually taken it and run with it. But we are going to roll it out for all head and neck patients because the results show that it is significantly better. And we're also going to tie it in with sorting out any problems we've had with the shoulderless and then maybe move to faceless masks. So thank you, that's it.